welcome to this evening's Facebook Live. My name is Alec. I'm the Managing Director for Wound Care People in the Journal of General Practice Nursing. This evening's session is post-COVID, what's next for shared care in wound management. And I'm delighted to say that I'm joined this evening by the wonderful Alison Schofield. Alison, are you there?
I'm here. Yeah, hi Alec. It's absolutely lovely to be back on the Facebook Live platform. All well and good up here in Yorkshire. Are you okay down in Wales?
Very good, very good. It's bright but very cold at the moment, so I'm looking forward to the real spring starting and the temperatures rising a bit. But I'm absolutely delighted to have you back. It's been a while since you've done one of these for us, and I think that tonight's session is a really interesting topic. So for all of you who are joining us, thank you very much for joining us. You'll see, as per the last few, or the last 12 months or so, we're doing these from our homes. So if there's any technical issues, do bear with us. One or two of you may have noticed that we've already had a slight technical issue right at the start. So we do have backups in place to be able to sort that out. So do just bear with us. I'd like to thank Hartman for sponsoring this evening's session. We've been working with Hartman now for the last 2 years to bring you a general practice nursing academy, which is available via our website, which has a whole host of materials that you can access. So do please check that out. We'll put up some links onto the page throughout the presentation. As always, we'll be doing a live Q&A at the end, so do ask as many questions as you can, and we'll try and get through to as many of those as possible. And the links to your certificate for attendance will be available following the live Q&A. That's it from me. I'm going to hand straight over to Alison to start the presentation. Alison, good luck. I will see you shortly for the live Q&A.
Okay, thanks Alec so much, and hello everybody. As I said, it's so good to be back with you and delivering this Facebook Live this evening. I hope you are all well. I hope you've had a good Easter, and importantly, I hope you've managed to get a little bit of time off and a little bit of well-deserved rest. Did you know actually today is World Health Day, and the theme for today is building a fairer, healthier world? So I think that's very pertinent for what we're going to be talking about this evening. So, oh my goodness, what a year that we have had the past 12 months. And our topic tonight is post-COVID, what's next for shared care in wound management. And I've written a few things in the past few months relating to this subject and the effects on wound care through the COVID pandemic as a whole. And I honestly think that the true fallout from this is yet to come. We will see it in due course. You know, we've just had an update on the burden of wound care by Julian Guest, and it showed there was an increase in the burden of wounds. The cost is above £8 billion annually to the NHS now, and certain wound types such as venous leg ulcers are ever on the increase. So it'll be interesting once we have that reflective look back to 2020-21 of where that will be, and I suspect that, you know, it's going to be much higher. So our learning objectives for this evening are going to be: what are the learnings from COVID-19 in relation to patient management? Will the effects of COVID-19 affect the way that wounds heal in the future? Shared care, self-care is now a part of the patient's journey. I personally feel that we're on the tip of the iceberg with this. So how do we fully embed this into practice? And what resources and guidelines are available, or what do you need to support this pathway? And what experience of using a shared care approach are in practice? What are you using, or what do you need? Please ask questions throughout. As Alex said at the end, you know, we'll be able to answer some of your questions. If we don't get to your questions in the next few days, I promise I will rewatch again. I'm going to answer personally every question that anybody asks with us. And let us know where you're from, which work areas you're in. This is the platform for Journal of Practice Nursing. You know, what are you in practice nursing? People from community nursing, or other areas of work. I'm sure we've got some of our fellow TVNs here tonight. So hello to all of you, and thank you for listening. So I just wanted to share with you a really interesting snapshot audit that I've done recently in my trust, in our practice. And this was just on 20 patients, and it was patients who are attending or have attended our chronic wound clinic, which predominantly deals with wounds to the lower leg. So these were 20 patients with leg ulcers. And when I did the audit, I looked at the start of their journey from when their wound occurred. And the majority of these patients, was so interesting because it was through the COVID period. So we know there were changes to services in that time in primary care. So the patients would ring the practice, predominantly they'd spoken to a GP. They would give, a little bit of history, talk about pain, etc., a deteriorating wound. They tried to self-care a little bit themselves unsuccessfully. So they were often given antibiotics. They were prescribed dressings to self-care themselves. There was a lot of Inodine and Mepor going on. Nothing wrong with those dressings, but in these particular wounds, it wasn't the right choice. So for these patients, the duration of their ulcers that they had, their wounds, ranged from a period of 3 months to 12 months before they were referred into our specialist service clinic. So their initial contacts, as I said, were via GP consultations. Most of them did eventually get appointments into primary care with their practice nurses. They were given certain dressings. It was a bit of shared care, and they were, and contacts as well. And I think the important thing is that, when we are talking tonight about shared care and self-care, and we need to have those structured processes in place to make it work better. So that's what we're going to talk about this evening. How can we help you to improve these practices for yourselves and for better quality patient outcomes? So for this audit, 14 of these patients were prescribed antibiotics initially, and some of them had quite, kind of repeated courses of this. And we have to remember the antimicrobial antibiotic stewardship. So we don't want to be unnecessarily overprescribing of antibiotics. So they were all prescribed the dressings initially to kind of self-care, and then they kept coming back saying the wound's deteriorated, it's not improving. But once they were referred to, and once they were seen by the appropriate services, they had the full assessments in place, they had optimal care pathways, and that also included a shared care pathway. We still managed to keep them on that trajectory, but 16 of those patients healed within 6 weeks. 6 weeks, and 4 of them healed in 12 weeks. Now, they were leg ulcers, as I said, so they were given, our first line is hosiery kits and compression wraps where we can, and with the absolute appropriate dressing management to suit that as well. So how will COVID affect the way that wounds heal in the future? So we know that COVID itself as a virus has had effects on the skin, on the tissue. We're still learning about all these things. We've heard of COVID toe. We know that patients in high dependency units, patients who've had to prone, have developed, deep tissue injuries. So there's kind of lots of that as a, intrinsic factor going on. But really, it's the COVID situation that's happened in the past 12 months that really has affected how we view and how wound care has been accessed, and what we've kind of gleaned from that, learned what's good and what's not good, that will affect the way that we view and approach wound care in the future. I mean, it's been unprecedented, hasn't it? The pressure on the services, the access that patients have had to services. And we must take this now, and we must stop, reflect and look and think, this is an opportunity to look at the way we are doing things and to change things. We have to challenge ourselves. We have to challenge our patients. And really, it can be quite exciting because we can shape the future to what we kind of want it to be. Wound care tissue viability is extremely nurse-led. We've got some evidence, we've got the burden of wound care. You can all do small audits within your own practices. You know, it's quite simple to look at your position where you are. What could we do better? And then let's bang on the doors of our senior leaders and our CCGs, you know, in your practices, your GP managers, and say, you know, we've got this evidence and we need to be doing things differently, because if we don't, we're going to end up in a much worse crisis in the future. Also, I don't know if any of you have had any involvement in digitalisation within the past 12 months. And, you know, the National Wound Care Strategy Programme have been doing some research and work around this. And I know there's some kind of free trials from certain companies around wound care apps, which are really exciting about measuring wounds. They talk to electronic patient records and kind of give you that real overview of what's happening within caseloads of patients with chronic wounds, especially within community settings. We've touched on telemedicine. I know a lot of GP practices will have done this, and certain other services. I myself have been remote triaging, you know, a lot predominantly. And, you know, we've kind of had to adapt to these digital systems, and it's worked very well. But the NHS needs to improve. You know, my grandson has a virtual reality kind of headset for his PlayStation. My work phone is, you know, kind of out of the Antiques Roadshow. So we know it's there. We need to do something about it. So it will be coming, and we can look forward to that. But we need to take that on board, because our patients, let's face it, a lot of people, even my dad who's 80 has got an iPad, and he can, you know, Google is his friend. And, you know, so patients are using smartphones, smart devices. And if we can link that together, where we are able to do the shared care, so they are sharing with us, it just really, really will improve that relationship and that partnership in the wound healing journey. So the COVID-19 pandemic drove a redistribution of healthcare workers across the NHS. And in some cases, this did impact on the, you know, frequency of appointments that patients had and face-to-face care. So, you know, some examples services have given to me is that some clinics at the time were suspended. Our chronic wound clinic was suspended. So we had to change the way that service was delivered. Patients accessing services in primary care. I'll give you an example, again, using my dad. He has hearing aids and his ears were blocked. He was told to get them syringed. The GP practice said, we're not doing that at the moment, with different services and different pressures. And there was no way he could get this done. So me being his loyal daughter and a nurse and trained in that area, I purchased for myself an ear syringing machine, and I've done it for him. He can now go to the hospital, get his hearing check done, and get his hearing aids renewed and in place. I'm qualified to do that, but let's remember that, you know, people out there, they you know, they don't have this knowledge, they don't have this awareness, but the services have been impacted. And remember back to my audit, where patients, you know, they're being given antibiotics, they're being given not the best, most appropriate dressings to deal with their shared care. So what we need to do is we need to empower our patients. We need to make sure that they're going to survive well, because, you know, that we could end up in this situation again. Hopefully we are coming out of the end of the, you know, we're coming through, aren't we? Coming through the tunnel of the COVID-19 pandemic. Hopefully we'll come out the other side, but we may get a third wave. We may get, you know, further types of viruses like this that occur in the future. So we need to be very, very prepared and prepare our patients. In primary care, you know, practice nurses, you know, you already do this with patients with diabetes, with COPD, with all asthma, lots of chronic disease management. You empower them to take ownership and empowerment of their own care. So let's turn this historic notion of wound care on its head. Do we really need to have a face-to-face contact of 2 or 3 times a week to change a dressing, when really it probably doesn't really need to be changed anyway? And we can give some of that ownership and education to the patient. They become part of the team, and we empower them to make those decisions for us. So we can really achieve something very revolutionary here in changing the way wound care services are delivered. So there seemed to be this urgency, and there was a lot of this talk around self-care, shared care, and it was kind of like the new kid on the block type thing, but we didn't have all the the right tools, the right pathways, the right documentation to support it. That was my feeling. And the National Wound Care Strategy programme did develop some documents, and if you access their website, there's some great resources, and there are things to support this. There's some videos. I think there's one of me showing how to kind of wash and care for a leg, and things like that, because there was such an urgent need for that advice. But we really need to back this up now. We need to make it part of standardized practice, and we need to be following, and not just doing our own bits here, there and everywhere. We need to be learning and taking from each other to support in what we're doing. So we need those tools to do that. So let's just recap on what those principles of shared care are. And I like the term shared care as opposed to self-care, because we are not saying to the patient, there you go, off you go, there's your dressings, carry on. It is a shared partnership after all. So we are involving the patients in their decision making. It really is so important to put the patient at the heart of this, and we are developing those plans of care together. Setting goals and arranging follow-up. So it's not our goals, my goal, your goal might be, so we, what does it tend to be? What do we set? Oh, yeah, wound healing. Well, that might not be the patient goal. I really remember when we did the video with a patient of mine, Diane's story for TVN Together, with a chronic pressure ulcer. And her aim and goal was to reduce the odour, because it affected her psychologically when her friends and family came to visit her at home. So do have that in mind, that your aims and goals may be extremely different to what your patients are. It may be odour reduction, it may be exudate reduction, because they're going out and about and they don't want leakage and showing and bulky bandages and all these sorts of things. So really do consider that in when you're planning your care. We need to help patients to understand what to look out for and how to get help. So that is those red flags. We need to arm them with all the correct information so they know when there's an issue, they don't feel abandoned. We set those reviews, whether it's a telemedicine call, whether video call, whether it's a telephone call, whether they're coming to see you in clinic or you're visiting them at home, but they need to know that it's okay. You've got to have the trust, the relationship, so they've got the contact, so that they know that if there's any issue at all, then they can they know that there's that two-way support for them. So it's so important to motivate patients, and how do we motivate patients? Well, if you give people all the information, the right advice, so we've got that good structure. It's a support network. When you've got something wrong with yourself, or you've been to the doctors and they say, oh, you've got so and so, or whatever it may be, what do? We Google, don't we? We Google our own conditions, and people do that. And Dr. Google doesn't give the best advice. So if we, as the healthcare professionals, are giving that full correct information, whether it's via leaflets, whether it's via verbal information, we are writing that into care plans, then, then we are much better able to get concordance on board with a shared care plan. So we need to be telling them, what is the skin? What does it do? If you get a wound, well, how does it heal? No, we don't leave it open to the dry air, which is an age-old, isn't it? Myth and thing. And if they get delayed in healing, well, why does that happen? If it's a leg ulcer, what's happening with the venous system to delay that healing? So knowledge is power. Let's give our patients, don't assume they don't understand, because believe me, they do. And we need to give people a better understanding. It's about creating a really, really good partnership and trust, but also with their carers and families also, because if somebody has a reduced capacity, it might be that it's the families or, the carers who are part of that shared care as well. And we've got a link there to the Self-Care Forum, which has got some really good information around that. So shared care is a real key driver at the moment for the NHS. It is part of the 10-year plan, the long-term plan. So I urge you to go and look at this, because there's a really good section on there around health coaching. And, if you think we've got an ageing population, obviously, which comes with that of long-term conditions, increased comorbidities, we've got that trajectory of the burden of wounds, we could have a repeat of COVID. We're still going through that thing. So let's set that scene now. Let's try and look at that holistic care management of, not just the wound care. We're talking about lifestyle changes and choices here, and all that comes in, what was health promotion and that health coaching. We're talking about diet. We're talking about, obesity control, exercise, all those things, because it's not just a case of, as we keep saying, putting a dressing on the wound. It's that whole holistic package. So we need to be putting a patient on a journey, which involves just part of that of the dressing management, but the shared care embodies all that. So let's act now before that terrible disaster movie issue strikes again. So think health coaching. So shared care is so important, because the patients who are living with a chronic disease often, it's not just the physical side of it, of pain and leakage, might be reduced mobility. It's those psychological emotions which are so important. And mental health and well-being have been so highlighted during the past 12 months. Can you imagine being isolated, shielding, and living with a chronic wound as well, and everything that comes with that? What would be the effect of that on your psychological well-being? I can't imagine that, and I think it would just be it's just massive, isn't it? And we have to look at the expectations of the patient and how we can, I keep saying the word empowered, but we need to bring them into this journey. So, if they can't have a visit that day, if they can't access clinics, as often as they can do, then let's give them the tools to be able to manage their own condition and to be able to support that. I think we owe it to them, and we owe that to ourselves. One of the biggest issues in wound care is definitely the effects of low mood and isolation, I would say. So the benefits to patients and healthcare professionals, there's various, isn't there? There's lots of different things. And for the patient, if within a shared care pathway, it gives them that sense of purpose. It gives them back the ownership of their their condition. They're not going to go, there you are, nurse, there's my leg, you know, it's their leg, give it back to them. Achieving those goals, setting those goals, you know, it's like yourself, don't you, when you know, we were talking earlier on our call about couch to 5k, you know, achieving, isn't it? And goals are different for everybody in every walk of life. So with a chronic wound, your patient will have, they'll have certain things that they want to achieve. So that better understanding, as we said, of their conditions and requirements and financial benefits. Let's not forget that not everybody with a chronic wound is of an older age, and that burden of wound care actually showed that the demographic of patients with venous leg ulcers actually was of a younger age group. And we've seen that in some of our audits that we've done as well in our trust. So some patients will have to go out to work and may not be able to work because of having a chronic wound. And also, you know, incorrect dressings, antibiotics. If you're paying for prescriptions, then quickly that's going to add up to a lot of money. And then they've got a motivational, not all wounds healed, and we have to accept that, and we have to sometimes acknowledge that. But where we can, there's more of a motivation to go on to healing if we're involved them very much in their own care. So the benefits to the healthcare professionals are, you know, a more effective use of our resources. So I recently did an add up of, in our district nursing services, over 7 days, 7-day period, and there were 893 contacts for wound care in 7 days. That was 70% of the workload. Now that is massive. And I spoke to some other TVNs in other trusts, and they said that's not unusual, that's quite common at the moment. And in your, you know, practice clinics, you might find that you're getting more contacts from people, you know, with wounds as well. So you might see that that's usual. So if we can put patients on a shared care pathway, then we are releasing nursing time as well to use in other resources, education, etc. So the quality of the treatment for the patient will improve because we're having a structured approach. We're getting the right dressings in there and the right, those lifestyle management issues. We're getting really good quality clinical outcomes, and the cost-effective fare, £8.3 billion in the burden of wound care to the NHS every year. You know, then it's higher than obesity. It's about number 5 in the chronic disease management list. You know, something has to be done about this now. So I have worked with Hartman. And what we did is we worked on, we wanted to provide something which was going to better arm people with the relevant tools to support you, both the healthcare professional and the patient, to develop a positive shared care partnership in practice. And we came up with this, which is HOME. So it stands for the Holistic Patient-Centred Care, the outline of a shared care action plan, management of a patient-friendly shared care pathway, and to evaluate and educate the patient for better shared care in the future. So I'm going to go through the elements of this in the documentation. So but it's fantastic. It just embodies everything that, you know, that we need to have in those support tools to take us forward. So it's a complete guide. It takes a clear look at the areas of a patient's activities of daily living. Now, those of you, those nurses amongst us, hark back to your student nursing days and your Roper, Logan and Tierney activities of daily living. I mean, wasn't that fantastic? And so we went back to that and we looked at that, because it's just the whole holistic package, isn't it? So we looked at, so within this document that you get, it goes through all those elements. It's based on, you know, aiming to maximise a patient's potential to be confident, have that ability to share some of the care, required to care for their wounds. We're not saying every single patient is going to go away and to do shared care or self-care. We know that's not possible. Everybody's an individual. So that's where you come in, and it's part of that assessment with your patients to ensure that they have the ability, the motivation, the mechanisms in place to do that. So the tools that are available within the home package that you will get is, we have a patient journal, and I love this journal. It's got holistic assessment. So you do this with the patient. So you go through all the elements, you plan, and you look at when you will see and review the patient, what are their goals and aims, and it's got really, really good friendly pathways within it. And then they can record, each week they can record their progress. They might want to take, photographs and things as well, but they record their thoughts, their feelings, how they think the wound has improved or not. We're not asking them to measure accurately and things like that, but, just in there, how they feel, how is the pain increased? Is there, they're more exudate, less? Are they happy with it? Are they not happy? So when you review them again, and it's there, isn't it? We document, so it will form part of that whole process. There's also some good big pictorial aspects as well, showing them different types of tissue and kind of what that will mean, and also about red flags, what to look out for, and when to contact. And so, and they've got all those contact details within it. So it's a structured shared care educational package. So it will provide you with all the necessary support tools to identify who is the right patient. You identify that with the patient. Who is the right person to go on this journey? It will enable you to support them, and for them, to have that two-way relationship. So it's just got everything. It's an all-in-one, let's say. So in our trust, and we've implemented this into one of our district nursing teams initially, but the plan is then that this will. I always like to start small. I start somewhere, and let's try it and see, how it works. And then we're going to roll it out, across the trust. So one of our district nursing teams, who is fabulous, and they are really into the health coaching and forward thinking. One of our DNs, Alison, she's a Queen's nurse and really supportive of this. And so she's identified with particular patients who we are going to take on this pathway. Each of them has one of the home packs. We've also given them, because part of this is that we need to get the right products as well. So we've given them a Zechavit plus silicone border, because some of you might be familiar with Zechavit as an absorbent pad. Well, this is the absorbent pad with the silicone border attached to it. So we showed the patients how to apply this dressing. And as I said before, on our pathway for patients with a lower limb, we have a first line of hosiery kits and compression wraps where we can. So this type of dressing is perfect, because easy to apply the dressing. You can put the hosiery kit or the wrap over the top if it is for a lower limb. And because it's the absorbent pad, it's got a longer wear time. It's going to hold lots of fluid, and it's just going to, it's going to last longer, and the patient's going to feel more confident and supported. So it's ongoing. It's not been long in the output, but the reports back so far, it's going successful. The district nurses are happy. The patients are really happy. They like the documentation that they really feel that they are part of the story and part of the journey. So it's all smiley faces and positive with that. A case study from another trust area is that the booklet and dressings were given to a patient in their trust. The patient had been self-caring for a while anyway, and they'd got a compression wrap in place, so it was a leg ulcer. and they'd be doing really well with this plan of care. But then being given the supporting documents, they found that filling the booklet in, they could look back, they could reflect themselves onto the previous week, they could see the changes. It's like, week to week, day to day, we forget things, don't we? So they could, read back and think, oh yeah, well, it's less painful, or there's less leakage, or it looks smaller, or, or deterioration, whichever that was. 1 week might not have been as good as the other week. So it caused her to change sometimes in things, maybe they'd been less active or too active 1 week. So they could change their lifestyle around to think, well, if we change this and I improve my diet, or if I stop smoking and things, then maybe that might help to improve my wound. So this lady, as a new patient, she thought the information in the document would be useful, and it helped her to record her shared care. She said the pack was informative, and she felt as well that it was aimed at a wide educational base. So it wasn't too simple, wasn't too overcomplicated with kind of medical, nursing terminology. So it really could be used across the board of age ranges and, for everyone. And even though she'd been sharing her own care for a while, she liked the information that came in the pack, the educational aspect. And so she learned some new things, and it reiterated to her some of the verbal advice she'd been given initially, but that she'd forgotten about. So just to summarise that, shared care is part of the government's long-term plan to empower patients and their families to take a more active role in their care. We need to identify what aspects of the care the patients can support and potentially will help improve clinical outcomes. So free up valuable resources that we need and improve overall patient experience. And so we using a real structured tool and method like Home that will give you the guide to support a patient successfully and get better outcomes, and give you that really good relationship in partnership planning. And just some key points I just want to finish on, that the cost of wound care is higher than managing obesity. Wounds account for generally 50% of community nursing, and that's 2/3 of wound care is within general practice and community nursing. Chronic wounds are generally given a low priority status in CCGs, and we often see a lot of suboptimal wound care because we don't have the access to resources and often to the educational and guidance to support us in that. Earlier interventions will give us better outcomes. NHS right care pathways, the framework, state that, and from a leg ulcer which can take 2 years to healing, to if we reduce that to months, is 10 times cheaper. There is a variation in practice across the UK, and the National Wound Care Strategy Programme work streams in lower limb care, surgical wounds, pressure ulcers are really working hard to standardise practice for that. But we need to take this forward, and we need to make this happen and to change practice. And we need to look at those digital solutions as well to go along with that. So we need to remember to assess. We need to look at the products we're using, such as the dressings, the treatment types, and we need to give good reviews, and we need to support our patients, because we can do this. It's up to us. We can make this change together. But I'm going to give you a call to action. So I'm sure, as we've been talking, you can identify particular patients who could take on a more active role in their wound care. And if you do, and if you want to uptake on the home care package and everything we've talked about today, you know, just contact Hartman. We've got a contact there, and you can discuss those ways of embedding and you know, this shared care structure into your everyday practice. So thank you so much. I think I've spoke a lot now, and I'm going to link back to Alec, and we shall your questions if you have any.
Thank you, Alison. That was a very good presentation, as always. Yeah, we've had loads of questions. I just want to say that I think the entire presentation actually is just really interesting. I really liked how topical it was, obviously given the COVID element, and actually how COVID, a lot of people I think would probably think that COVID was what sort of has forced the NHS into thinking about shared care, but actually is something that they've been working on for a very long time. I think that what COVID has done is it's just given us the impetus and the boost to be sort of thinking about doing this. And I know that Hartman certainly have put a lot of effort with the likes of yourself into creating these resources for nurses. So as part of the call to action, there should be a link on the screen now for you to be able to contact them if you want any more information about this. So please do so. With that in mind, I'm going to go straight over to the questions. There's quite a few of these. The first question is from Jane, and this is: how do you empower a patient to want to share the care if they're apprehensive?
I would say so if you've identified and assessed that this, you know, with the patient, this is an appropriate pathway that they could take, and yes, they are a bit apprehensive, so you need to build up a real trust and relationship with the patient. You need to give them the knowledge, the tools. You need to make sure that they feel confident, you know, to follow on. And I think everything that's there, that, you know, and if you give them you know, like they say, the contact numbers, the red flags and things like that, so they're not just going away thinking, oh my god, I'm on my own with this, what am I going to do, you know. Just arm them with the tools. You don't have to do, you know, it doesn't have to be one visit and that's it, you know, off you go. It might take a little bit of time to nurture and to enable that, but that, you know, the kind of the trust, the knowledge, the structure is important.
Would you think as well that it's really important to emphasize the fact that it is shared care and not actually just making them care for themselves? It's about actually giving them the power to be able to help themselves. It's not taking away what the nurse is going to do or what the other, you know, whatever healthcare professional is going to be providing. It's just sharing some of that responsibility.
Yeah, I think that's really important. I think we've had such a change over the past 12 months in accessibility to service, especially in general practice. I think it's really important not to isolate the patient in, you know, I did see an element of that in some of my in some of my audit, and so you need to have the proper structures in place, and the patient then won't feel like that, you know. I think with any health condition, as you know, I'm a nurse, but as a lay person, you know, I see that within my family. People get worried and stressed about things, and you just need that person there to reassure and to arm you with all the tools and the knowledge and the information, so they feel, you know, that they're not on their own, that they are supported.
Yeah, I think just obviously emphasizing the positive message around empowering them to help themselves and sharing their care, rather than saying, right, this is what you do and we'll see you in 2 weeks or whatever. So I think that's certainly what I would say. The second question is from Alex, and this is: not all patients can get to their wounds to redress them. Would you agree that those patients need face-to-face meetings?
Yeah, I mean, as I said, you know, at the end of the presentation, you know, we aren't saying every single patient can share care. You know, I've in my 20-year nursing career, I've come across a lot of patients in community, And there are certainly patients, as Alex said, who cannot just physically, access their wound, or, people with rheumatoid arthritis, for example, they've got problems with their dexterity, their hands, they can't bend down. So it's not, you have to do that assessment with the patient. Are they going to be able to do it? But if they can't, is there a family member or a carer that can share care with you? And if you can't do shared care, just sit and reflect on your care plan. I talked about the historic care of 2-3 times a week, scheduling visits. Does it really need to be that? If you've got the right, systems in place, you maybe you're doing more harm than good by changing things too often. A good, set of leg ulcer, if they're suitable for like a hosiery kit, compression stocking or something, and somebody can assist to support in that and addressing, then maybe you don't need to be, kind of intervening too often. But yeah, it's up to you. You have to do that on an individual basis of planning a care with your patient.
I think that's good advice. Question 3, as a healthcare professional, what gives you the confidence to instigate shared care with a patient?
So what would give me confidence as a healthcare professional is that I know I've done the correct assessment with the patient. I know that they're, they are suitable, that they're able, that they are willing, and that I've given them, the tools to be able to do the job. So they've got the education, the knowledge, they've got all the home pathways that we've talked about, and the products to do that. So if I've done this quite a number of times, and sometimes, honestly, you wouldn't believe some of the wounds where we've got families and carers and patients themselves to support in their own care. But it is doable, and you just sometimes have to be creative, and you have to sometimes let go a little bit as well. Just have that trust with your patient.
Yeah, good. Thank you for that. So question number 4 is from Janine, and this is, when patients are seen less by a professional, is there the potential for being treated for longer with inappropriate dressing choices impacting on costs?
Well, this is the thing. If we give them the right assessment to start with, if we give them the right products to start with, which is suitable for their wound. So we're looking at the TIMES assessment framework. So we're choosing the suitable management to go with that for that wound, then we're okay. As I said in my audit, I saw a lot of Inadine and Meepo and all sorts of other things being prescribed and applied, but that assessment wasn't right. If we do it right initially, right care first time, then we're okay, we're on the right track. If we don't, then yes, we are going to get deterioration. We're just going to get products, spend, and things like that, and we're going to get longer to heal it.
Excellent, thank you. Question number 5. What's the most important aspect of starting a shared care journey?
I would say the most important to start it is to have that trust and relationship with your patient. You have that conversation, have an initial conversation. If they feel, kind of empowered to it, if they feel that, and we must empower them as well. Just don't think, oh, well, Mrs. Smith down the road, she's kind of never going to be able to do that. How do we know until we start a conversation with them? So, let's just kind of open it up, and if we give them all the tools to do the job, and we're confident, and if it doesn't work out, it doesn't work out, and we might need to step in a little bit more at first and things like that. Or we've had some patients where they've been like, no thanks, we'll ring you when we're ready, and some are a little bit more dependent. Everybody is individual, and so if we treat them that way, then you should be fine.
Okay, question number 6. This is from Jenny. When wouldn't you advocate a shared care approach?
So as I said, not everybody is suitable for this. We can't just say to a patient who, as I said, an example is somebody who has dexterity issues, physical issues, well, there you are, apply your own dressing to your leg or your foot, and your hosiery and things like that. If it's not going to happen and it's going to be a safety issue, then that's not appropriate. Maybe that's somebody's end of life, or there's lots of different situations. It's just such an individual assessment. So that first initial assessment from a psychological, physiological point of view was if that patient is going to be able to undertake this or not, is vital.
I think the one thing that's quite clear is that even though all the questions have been different, actually it's the same thing really, which is so it's making sure that you assess the patient, and as part of that assessment, it's deciding whether they're suitable for shared care and what level of shared care. So it's they're all very much linked. Question number 7. This is from Katie, and this is: can partners be part of shared care and help change dressings for their partner?
Oh, yes, they can. Do you know what? We had a patient who had a surgical wound from hospital. And the patient, she didn't want to stay in. She wanted to go home, and it was a sacral surgical wound. And so we taught the patient's partner to do the wound dressing. Initially, we thought, oh God, this is going to be, he's not going to cope with this, because it was a substantial size, and and everything else, and leakage and all the rest of it and stuff. But they did it. They were determined. This is what they were going to do. We supported them. There was a follow-up in community after that, and they carried on and they did it. So absolutely, families, partners, carers, if they're willing to do that, and some people feel quite comfortable to be able to do it, so yeah, give it a go.
And actually, when that question came up, it got me thinking about something I was thinking about earlier when you mentioned home and the pathway and the packs that the Hartman can send out, and actually getting carers, partners, family members who are caring for these people to actually be filling out the helping to fill out the home pathways. It seems like as well a natural progression for this. I've not spoken to Hartman about it, but I'm sure they've thought about it. But a natural progression for this would also be like making this a digital campaign, as well as a print one. So maybe an app or a website, and then you can do things like introduce what you were talking about earlier, like taking photos of wounds. So maybe a carer can take a picture of a wound, upload it to the home app or the home website. Maybe then the district nurses can see that before they go and visit, so they can almost do a virtual assessment before they actually go out and do the visit. So I really like it, and I think the opportunities with home and shared care support are limitless at the moment. I think there's lots and lots of ways that you firstly get people really thinking about shared care, and then the opportunities will open up. Apologies to Hartman if you've already got that in the pipeline and you're thinking of doing it, but it all seemed to make sense to me that would be the next natural progression for home.
Yeah, I agree. And I think, like I said, I kept saying, I think we're just on the tip of the iceberg with shared care. We've dipped our toe in, but we need to firm it up. And then there's all this kind of, it's fresh, isn't it? Digitalization, wound apps and things like that. And we live in such a virtual digitalized world, but kind of but then when we come back into the NHS, we're not there with it yet, but we need to really take that forward. And if you look at the home document, the books and everything, they're so great. And like I said, that we have a lot of patients, especially patients coming into GP practices and into clinics and stuff, they might be of a younger age as well. People are using these things now, so I think it's exciting.
You could link it to diaries to book appointments,
Yeah.
reorder dressings, and all sorts of things. We'll take that offline because I think I think we'll speak to Hartman about that. We do have one final question before we go, and this is from Judy, and this is: how can we improve shared care between primary and secondary care? Home would be an excellent tool to support nurses to continue with the appropriate care agreed in hospital.
Oh, do you know? Yeah, and I didn't mention this, and I meant to. So thank you, Judy. You've just reminded me of about talking about MDT working. So between primary, community, secondary care, because the patient goes on a journey, a cycle of care often. And now our CCGs are becoming the ICSs, integrated care systems. So that kind of, with all those, the kind of the transforming NHS services plans is becoming closer and closer. So we do need to look at that. I mean, I know for one thing, say for like example with catheter care, they have catheter passports. In my trust, we have leg ulcer passports. So we could do that with home. So it's kind of like it's the wound passport. So it follows the patient through that cycle. And I think better so if it becomes digitalized, then you're not getting things lost or forgetting to take them in if you go in as an inpatient and things like that. But I think anything that improves that journey of that, because I work on a basis of System 1 records for patient access. Our acute service is still using written records, and kind of you do get that delay and that misinformation. So I think it's something we need to look at and definitely work on with this.
Excellent. Well, again, I'm sure that the Hartman will be thinking about that as well. So that's the end of the live Q&A. Alison, as always, it's been an absolute joy to have you presenting for us. So thank you very much. I'd like to thank Hartman for supporting this event, and as I said at the beginning, as well as being able to get access to the information, or to more information about Home, where there should be links on the screen where you can contact those directly for that. We've also got some educational content that we've been working on with Hartman over the last 2 years as part of our General Practice Nursing Academy. So do please check out our website and go and explore that. The link to the certificate should be available for you to download now. Don't forget, this event does count towards your CPD. We would like to thank you all for joining us. Again, thank you to my team, thank you to Mole, thank you to everyone involved, and thank you all for joining us. We look forward to seeing you all again soon. Good night.
Good night, everybody. Thank you.